Hi, I'm Shama. I'm a third year MBBS student at Government TD Medical College, Alapura. Today, I'm going to be taking the topic obstructive lung diseases. So I'll give an overview of what all we are going to cover today. I'll give an introduction about the anatomy and the histology of the respiratory tract. Then we'll discuss the definition of COPD. Then we'll move on to two COPD cases that are chronic bronchitis and emphysema. So let's begin. Let's begin with the anatomy. We know that the conducting passages can be divided into the upper respiratory tract and the lower respiratory tract. The upper respiratory tract is composed of the nasal cavity, the pharynx and the larynx, and the lower respiratory tract is composed of the trachea, the primary bronchi, the divisions of the bronchi and the lungs. So what are the divisions of the bronchi? There are two primary bronchi, and these primary bronchi will each divide into segmental bronchi, large subsegmental bronchi, and small subsegmental bronchi, which will further divide into bronchioles. What are the divisions of the bronchioles? We are having terminal bronchioles, which will end in respiratory bronchioles, which will continue as alveolar ducts and alveoli. So here we can see the acinus marked. What is an acinus? An acinus is very important in COPD, especially in emphysema. It is a respiratory unit that is affected in emphysema. It is composed of the respiratory bronchiole, the alveolar duct, and the alveolus. So that is the anatomy of the respiratory tract in brief. Let's move on to the histology. What are the layers of the respiratory tract? There are mainly four layers in the respiratory tract. They are the mucosa, the submucosa, the muscularis and the cartilaginous layer. The mucosa is composed of the epithelium. As we all know, the epithelium that is lining the respiratory tract is the pseudostratified ciliated columnar epithelium, which is containing goblet cells. And we have the lamina propria, and there is a muscularis mucosa that is followed by the submucosa. What does the submucosa contain? Here you can see this is the submucosa. It is containing numerous submucous glands which produce mucus. Then we are having the muscularis layer and we are having the cartilaginous layer, which is composed of hyaline cartilage. So these are the four layers of the respiratory tract. Now let's discuss the definition of COPD. What is COPD? The COPD is basically defined as a disease state which is characterized by chronic airflow limitation that is not fully reversible. And there are four conditions under COPD. They include emphysema, chronic bronchitis, bronchiectasis, and bronchial asthma. Today we'll be discussing about emphysema and chronic bronchitis. So let's start with a case. A 65-year-old male presents with progressive breathlessness for 5 years. The dyspnea initially occurred on exertion, but now occurs even at rest. He has a long history of smoking, that is 40 pack years. This is significant. He reports minimal cough even but with scanty sputum. And on examination, he has a thin appearance and he has a barrel-shaped chest and he uses the accessory muscles of respiration. He has pursed lip breathing and hyper-resonant percussion mode. And the chest X-ray shows hyperinflated lungs with flattened diaphragm. What are the questions? The likely diagnosis, what type of emphysema is associated with his history, why is the patient referred to as pink pufferin emphysema, and what is the pathogenesis of emphysema? So I will not be discussing the answers to these questions. After covering these slides, you should go back and try to answer them. Let's start with the definition of emphysema. We discussed the respiratory unit, the acinus, right? So basically what happens in emphysema is that this acinus, which is composed of the respiratory bronchiole, the alveolar duct and the alveolus, will be dilated. There will be irreversible dilatation of this acinus. It can be the whole of the acinus or it may be only partly involved. So that is the definition. It is a chronic lung disease which is characterized by permanent or irreversible dilatation of the air spaces that are distal to the terminal bronchiole, which is the respiratory acinus. So let's discuss the types of emphysema. The types of emphysema is based on the part of the acinus that is affected. I mentioned earlier that the whole of the acinus could be affected or a part of it could be affected. So there are four types. There is centriacinar, panacinar, paraseptal, and irregular. In centriacinar emphysema, we can see that the proximal part or the central part of the respiratory sinus is affected, which is the respiratory bronchioles. And in pan-acinar emphysema, we can see that the whole part of the sinus is equally affected. Moving on to paraseptal. Which part of the sinus is affected? The part of the sinus which is next to the septum is affected, which is why it is called paraseptal emphysema. Then here we have the irregular emphysema. Here we can see the parts of the sinus which is affected are irregular. There is irregular involvement. That is why it is called irregular emphysema. So let's move on to the types of emphysema in detail. Starting with centri-acinar emphysema, it involves the central or the proximal parts of the sinus which is formed by the respiratory bronchioles, and the distal parts will be normal. So in a patient who is having centri-acinar emphysema, there will be both normal air spaces and there will be emphysematous air spaces in the same lobule and sinus. And which part of the lung is affected? It is more severe and common in the upper lobes, especially the apical segments of the lung will be affected. And it is associated with heavy smokers, and it usually occurs in combination with chronic bronchitis and cold workers pneumoconiosis. The case that we discussed before, the patient had a history of 40 patches. So he is likely to be having centri-acinar emphysema. And also the walls of the emphysematous lobules will often show black pigment in centri-acinar emphysema. So that's about centri-acinar emphysema. Let's move on to the next type, which is pan-acinar or pan-lobular emphysema. Here, all the air spaces beyond the terminal bronchiole will be equally dilated. And it is mostly common in the lower lobes, unlike centri-acinar emphysema, where the upper lobes are involved. And in centri-acinar emphysema, the apices of the lungs were affected. Here, the disease is most severe at the bases. And it is associated with genetic defect, which is the alpha-1 antitrypsin deficiency. So that is about pan-acinar emphysema. Now let's move on to the distal acinar or the paraseptal emphysema. This emphysema affects the distal air spaces at the periphery of the lobule, and the proximal portions will remain normal. And what are the dimensions of this emphysema? The affected air spaces will be multiple and enlarged, and they will range from less than 0.5 centimeters to more than 2 centimeters in diameter. And there is a formation of a special structure that is known as a bullae in this type of emphysema. They are basically dilated air spaces which are more than 1 centimeter in size. And when these bullae will rupture, they will cause spontaneous pneumothorax. And which part of the lung is affected in distal acinar emphysema? It is mostly near to the septum, as we saw in the figure before. It is the parts which are adjacent to the septa and adjacent to the pleura, or it will be present in the margins of the lobules. And it is more severe in the upper lobes. And it is usually associated with forces which are pulling on the septa, and it will occur adjacent to areas of fibrosis, scarring, and atelectasis. So that's about distal acinar emphysema. Let's move on to the last type, which is irregular emphysema. As its name indicates, the parts are irregularly involved, and it is the most common form of emphysema. And as the sinus is irregularly involved, this may be asymptomatic. And it usually occurs near scars, mostly near old healed inflammatory scars and near tubercular scars. Let's move on to the pathogenesis. We discussed the types, the 4 types. Let's discuss the pathogenesis now. There are 2 main factors which are involved in the pathogenesis. There is genetic factors and environmental factors. The environmental factors, as you may have noticed from the question, we discussed about tobacco smoking. Tobacco smoking is a major factor which is involved in the pathogenesis. Also, exposure to fumes from toxic fuels can also cause emphysema. Along with that, when there is a genetic factor such as alpha-1 antitrypsin deficiency, which is basically an anti-protease that inhibits the action of protease, there will be an increased susceptibility towards emphysema in these patients. So what happens when there is a combination of these 2 factors? When there is inflammation and when there is alpha-1 antitrypsin deficiency. Initially, there will be inflammation. That is, macrophages will be releasing inflammatory mediators like leukotrienes, interleukins, and tumor necrosis factors. And all these inflammatory mediators which are produced will induce an inflammatory reaction, and it will produce proteases. These proteases will act in an uninhibited manner because the antiproteases are genetically deficient. There is a deficiency of the antiprotease, so they will act and they will destroy the alveolar parenchyma, due to which there will be emphysematous changes in the air spaces. So that is the pathogenesis. Now let's move on to the morphology. So in gross morphology, mostly the upper two-thirds of the lung are affected, and bullae will be found in irregular emphysema and in distal acinar emphysema. And when the emphysema condition is more advanced, there will be voluminous lungs. Now let's move on to the microscopy. First, check out this figure. Here we can see the comparison of a lung that is having emphysema and a healthy lung. We can see there are several dilated spaces. They are present in the lower lobes of the right lung, and they are present in the lower lobes of the left lung. They are markedly enlarged in emphysematous lung, and the normal lung, there is no apparent disease and it is healthy and functioning. So can you identify these structures? These are the bullae that we described. It occurs in irregular emphysema and distal acinar emphysema. It is mostly present near the margins of the lobules and near the pleura and near the septum. Next, let's discuss the microscopic changes which occur in emphysema. So the lung will show abnormally large alveoli because of the destruction of the walls, because of the action of proteases. And the attachments of the alveoli to the outer wall of small airways will also be destroyed, and the pores of Kohn will be enlarged. And in advanced disease, bullae will be seen, and along with that, due to smoking, inflammatory changes will be present in small airways. And here we can see a diagram. There is destruction of the alveolar walls over here, and there is formation of large irregular alveoli. Now let's discuss the term pink puffers. So about chronic bronchitis and emphysema, we cannot, in most of the cases, we cannot say that this patient is showing only symptoms of chronic bronchitis or only symptoms of emphysema. Usually the patients will be in a spectrum. They will show a combination of these features, and one feature will be predominant. So in this spectrum, patients in whom emphysema is predominant are called as pink puffers because of the characteristic symptoms they show. What are these symptoms? Check out this diagram. You can see that this patient is older and thin. Mostly the older individuals will be affected in emphysema, and they will be thin. There will be marked weight loss, and the patient will have a barrel-shaped chest. And their posture. What about their posture? Check out this person's posture. He's having a hunched over position, and he's breathing through pursed lips. What about his cough? His cough will not be that predominant, and the most common presenting symptom in emphysema is dyspnea. There will be marked and severe dyspnea in emphysema, and the blood gas values will be normal in emphysema, and weight loss, as I mentioned before, will be common. What does the X-ray reveal? The X-ray will reveal hyperinflation of the chest, and it will reveal flattened diaphragms. So this is the description about the term pink puffers that I mentioned earlier. They are called pink puffers because they are barrel-chested, and they will have prolonged expiration. They will have pursed lips. They will be sitting in a hunched over position, and marked weight loss will be present. So let's move on to the clinical course. As I mentioned before, dyspnea is the predominant symptom in emphysema, and cough and expectoration will occur, but it is not that predominant. Weight loss is, however, common, and on clinical examination, there is barrel-shaped chest and prolonged expiration. Along with that, the patient will breathe through pursed lips. What are the complications of emphysema? The complications include poor pulmonale, congestive heart failure because of secondary pulmonary hypertension, and pneumothorax. So these are this is the clinical course of emphysema. So we discussed about the definition of emphysema, the types, we discussed the clinical course, and we discussed the morphology of the lesions which are formed, and also the pathogenesis. Note that the protease antiprotease hypothesis is very important. Now let's move on to the next case. A 50-year-old male who is a chronic smoker presents with productive cough for the past 3 years. He reports that the cough occurs daily for at least 3 months each year and is associated with sputum production. He also complains of mild breathlessness. On examination, he has an overweight build, mild cyanosis, and bilateral bronchi and auscultation. What are the questions? What is the most likely diagnosis? What is the diagnostic criteria for chronic bronchitis? Why is this patient referred to as blue bloater? What is the pathogenesis of chronic bronchitis and the histopathological changes? What is the role of smoking and the complications of chronic bronchitis? So we'll be covering all these topics. You should go back and try to see if you can answer these questions by the end of this session. So let's start with chronic bronchitis. You can see in this figure, there are two terms, inflammation and excess mucus. Keep these two terms in mind. They will help you to explain the pathological changes and the pathogenesis of chronic bronchitis. Inflammation and excess mucus. So let's move on to the definition. Chronic bronchitis is defined clinically as persistent cough with sputum production for 3 months in 2 consecutive years in the absence of any other identifiable causes. So that is the definition. Persistent cough for 3 months in 2 consecutive years in the absence of any other identifiable causes. Let's move on to the pathogenesis. Remember the two terms, inflammation and hypersecretion of mucus. How does inflammation occur? As we mentioned in the case, the patient that we described was a chronic smoker. The initiating factor in chronic bronchitis is the irritation of the airways by the inhalation of smoke or any other irritants such as dust, cotton, sulfur dioxide, nitrogen dioxide and silica. However, the main air pollutant that is involved is obviously tobacco smoke. 90% of patients who are affected are smokers. And because of this irritation, there will be inflammation and infiltration by the CD8 plus T lymphocytes, macrophages and neutrophils. So that is the first factor that is involved. There will be irritation. The next factor that is involved is hypersecretion of mucus. The mucus is produced by the submucous glands which are present in the submucosa. We discussed it in the histology. And these submucosal glands will undergo hyperplasia and hypertrophy because of the irritation that is produced by the pollutants that this person is inhaling. There will be hypersecretion of mucus. And along with the hypertrophy of the submucous glands, there will be increase in the number of goblet cells which are present in the respiratory epithelium. You should recall that the pseudostratified ciliated columnar epithelium has goblet cells. There will be increase in their number which will produce excessive mucus, and this mucus will lead to the plugging of the bronchial lumen, which will lead to the fibrosis and the inflammation of the bronchial wall. This will cause airway obstruction. So these are the two main factors, hypersecretion of the mucus and inflammation, and the initiation is by the inhalation of air pollutants, mainly tobacco smoke. So let's move on to the morphology of the lesions which are produced in chronic bronchitis. What are the changes in the airways? Both the large airways and the small airways will show changes because of the two factors, because of hypersecretion of mucus and because of inflammation. How will the mucous membrane appear? Obviously, there's inflammation, so it will appear red in color. It will appear dusky red. It will show hyperemia, swelling and edema. And the lumen will be filled with the mucus that is produced. It will be filled with excessive mucus or mucopurulent secretions. So that is the morphology, the gross morphology. Now let's move on to the microscopy. So this is the normal lung and this is the lung in chronic bronchitis. As I mentioned before, there is hyperplasia and hypertrophy of the mucus secreting glands in submucosa. As we can see here, there is marked increase in the number of the submucous glands. So there will be increase in the thickness of the submucous layer and an overall increase will be there in the thickness of the respiratory epithelium. So we can calculate an index. Try to calculate B by A. B by A is also known as the Reed index. The Reed index, how is the Reed index affected in chronic bronchitis? There is increase in the number of submucous glands. So the thickness of the submucous glands will increase. When the thickness of submucous glands will increase, the whole thickness of the respiratory epithelium will also be increasing. So there will be increase in B and there is increase in A. Because of this, the Reed index will increase from its normal value. So, as I mentioned before, Reed index is the ratio of the thickness of mucous gland layer to the thickness of the wall between the base of the surface epithelium and the inner limit of the cartilage plates. And it is useful for detecting the increase in size and number of mucous glands. Normal value of Reed index is 0.4 and it will be increased in chronic bronchitis. It will be more than 0.5. In severe cases, it can reach up to 0.6. So that is the read index. What are the other changes which are seen in microscopy? There is inflammation, right? So there will be chronic inflammation of the airways, which will result in infiltration of the airways by lymphocytes. Along with that, the surface epithelium, as there is hypersecretion of mucus by the goblet cells, there will be increase in the number of goblet cells, and also there will be metaplasia. The pseudostratified ciliated columnar epithelium will be converted into squamous epithelium. So there is squamous metaplasia. Along with it, what will happen to the bronchioles? There is hypersecretion of mucus. So there will be narrowing of the bronchioles. And there will be thickening of the bronchial wall due to the hyperplasia. And in severe cases, this lumen will be completely obliterated because of fibrosis. This condition is known as bronchiolitis obliterans. So what are the microscopic changes? There is hyperplasia and hypertrophy of the mucus secreting glands in submucosa. There will be increase in the number of read index above 0.4, and there will be inflammation of the airways, there will be infiltration by lymphocytes, and there will be squamous metaplasia, and increase in number of the goblet cells in the surface epithelium. There will be narrowing of the bronchioles, there will be fibrosis, there may be obliteration of lumen in severe cases which can lead to bronchiolitis obliterans. So these are the microscopic changes. Let's move on to the clinical features. And as I mentioned in the case, the person who was affected was 50 years old. Chronic bronchitis will usually affect middle-aged men who are heavy smokers. And early smokers will have early symptoms will be persistent productive cough for many years. And on later stages, there will be dyspnea on exertion. The main symptom in chronic bronchitis is cough with sputum. Dyspnea will occur only in the later stages, and it is not as prominent as in emphysema. This is how you differentiate between emphysema and chronic bronchitis. And in patients with pure chronic bronchitis, they are also referred to as blue blotters. That is, in one end of the spectrum, in patients with purely emphysematous signs, we are having pink puffers, and on the other end, in patients with predominantly chronic bronchitis symptoms, we are having blue blotters. What are their symptoms? There will be mild cyanosis. Check out this blue man. He's having cyanotic, he's overweight, and he has edema. He has bronchi and wheezing. He's having hypercapnia, and he's having chronic productive cough. And you can see that he's a heavy smoker. So this is the term that is used to describe patients who are affected with chronic bronchitis. They are referred to as blue blotters. So these are the clinical features. Let's move on to the complications. What are the complications? This chronic bronchitis can progress and it can result in chronic obstructive pulmonary disease. And the long-standing cases can lead to cor pulmonale, that is accompanied with cardiac failure. And some patients will develop squamous metaplasia, and there may be dysplasia of this respiratory epithelium, and this will lead to cancerous transformation. So we discussed the complications, we discussed the clinical features, we discussed the morphology and the pathogenesis of chronic bronchitis. So you should go back and try to answer the questions which were there in the first slide. Thank you. I hope you understood this topic.